All right. So hello, dear doctors. This is your mentor, Dr. Shahriar. Those of you just now joined, we already finished the respiratory system and we have posted the recordings. Please make sure next time you finish the recordings in 48 hours, actually. Okay. This is to, make the class and, regularity more clear, actually. We were talking about the question bank. Question bank will be posting. Question banks, I don't recommend you to buy, but if you have a lot of like financially stable question bank has, if you subscribe to a question bank, it has a nice pattern of coming compared to the PDF. In that way it's more nice actually for solving. You can solve in mobile, that's okay, but PDF you can also solve. The question is, do I need separately the question banks again to subscribe? Practically speaking, not much needed. You can save that money and you can focus more on the uh, recall solving. Now how we can solve more recall, I'll be showing in the guideline group. Okay, like a more recall. I'm giving you a demonstration of solving a little bit more recalls. As we mentioned earlier, for recall solving, this is your forum. There are like very huge number of members, not only our students, many other MC students. And this is the largest group for MC for discussing the recalls actually. So many people, they keep discussing all the time actually in this group. We were also talking about the sticky notes. Now see, this is a past thing of one of our doctor actually. Yes, these are the things, sir. How you get previous year recall question? We are already posting the files actually. Okay, so this is the thing. Class, this is included. Also forum included. Also there are recall courses separately. Okay, so there's so many. Depends on how much you want to put effort actually. If you have a study partner, if you have nice group, there's so many. Like we have the best group for recall solving. Other than that, you can also, there are some WhatsApp group, Telegram groups. I am not familiar or I'm not in those groups, by the way. Students make their own groups. You guys can make your own groups actually. So people eventually find sources. First of all, make sure you finish whatever task is given. Initially, you are in a beginning phase. So please try understand and please try adapt the system. If you're like trying to over jump, what will happen? You will fall down very badly. So initial part, I'll highly recommend you to finish up things clearly. All right. Video will be deleted after 48 hours. Yes, that is correct. Okay. Now, next coming is the thing is a sticky note we were talking about. Sticky note kind of thing. As you can see in the sticky note, see one of our doctor, how much effort the doctor has put. Trust me, many of our doctor also put effort like this. That John Murtagh, they also add pages like that. Some of them, for the exam purpose, they also add notes like this. Isn't it amazing? I will guide you more during the cardiology class how to make more precise sticky notes actually. So far about the websites we have mentioned, other than the John Murtagh, what additional references we can use? Example, RCH guideline. Example, can you tell more website names? Yes, one is a John Murtagh, one is a RSCGP, one is a RCH guideline. Yes, please. And another one is a rank cause. SA Health, anything related to .au. SA Health, yeah, fine. South Australian. Med Bullets, another good one. Therapeutic guideline is a good one. So many relevant, whether Radiopedia for the radiologists, by the way. I'll tell you more, so do not worry actually. NCBI. Now, see, NCBI is a not too strong. So example, I do also have some publication and those are also under NCPI. It doesn't mean those are proven. Are you clear now? Dr. Khadija, I think, asked me the question. So anything like a PubMed and Cochrane, uh, like you can establish a case study and it comes in the search engine in that way. Okay. It doesn't mean those are proven. Is it clear to doctors? So you need to find out why proper website. Medscape is also good one, by the way. AAFP is also good one. But Medscape and AAFP are not the Australian. Australian Authentic is more recommended, which is John Murtagh. But John Murtagh get updates in 5 years. Other than that, RSCGP, RCH guideline, any proper website with .au. Okay, another one I'd like to highlight, imaging pathway. as well. So .au related, many things will be there. So imaging pathway. Now, why we need these websites? Okay, so why we need these websites? It is because uh, solving more recall, we need more authenticity. There will be so many confusion. The more the confusion, understand one thing, your concept will be developing more and more as the time progresses. Is it clear to dear doctors? Concept will grow. As the more confusion and things are there, that is the reason. There is nothing like that. You just finish this amount and you will pass the MC, nothing like that. The more you clarify your confusions, the more you discuss with your friends, the more you will revise at the end. I'm telling now you need to organize and at the end, more revision. Like as you see in the picture, the more revised, this is a way like, so two computers, more productivity. In cardio section, we'll be talking about productivity more. Okay, so things would be more easier that particular time. All right, guys. So this is interesting. It would be more clear with time. I can guarantee you things would be more clear with time. Don't be panic. First 2 weeks are like, we already mentioned, first 2 weeks are like what? First 2 weeks are like, just to understand the processes. Great. So this is the other things that is going. Yes. Now we have that batch 59 as well. If anyone joined late, we have already opened GIT inquiry zone. Most of the questions have been answered in the respiratory inquiry zone. I will again double check. Of course, I'm a busy person as well. Uh, last 24 hour, I didn't check. I will check now. I mean, maybe after class, if any inquiries, I'll check again from the respiratory. Again, one more information, directly do not copy paste the recalls here. You need to ask in a conceptual. Same recall thing you can ask in a conceptual way. That is how your conception will develop. Please understand, I'm a teacher, I'm a national award winning teacher. Conception is very important to develop from or to increase from the students. It is very, very important actually to develop the concepts. Forget about whatever you have learned in this, that I am a teacher of even many teachers as well. So I'm not getting there about the techniques and this, that. You need to trust me, that's the most important part. Okay. Again, about posting the recall, post recalls, and you all try to participate there. I want you guys to see that participating more, posting a question, and some others are also participating. Now, question is, can you guys do that? I want some answers in the comment section. Will you guys going to do it regularly from now on? Like posting and statistics shown, those have been regular in the guideline room. They all passed in first go. Now it's your decision which group you want to be. Okay, those are more private people. Those are more like private people. The chances sometimes narrow because more private means they don't want to open up. They don't discuss um, in front of others. They don't like it. They just want a private study partner. See, when we used to study, we used to have forums. We used to also discuss with our friends as well. So example, I used to have two study partner or group. One, he was dedicated. Now he's a doctor already in Australia. All of them are now Australian doctors. One used to come to my home, or we used to go to library sometimes. Then we come back. Then with some overseas group, I used to make calls. Actually, that time Zoom was not popular. Through the Skype, we used to make call because Skype is free. Zoom is also technically free, but for 40 minutes. I mean, for the regular people. Now that is how the things are. You can make it 2 or 3. I recommend always 3. I recommend 3 people study group. Why? You make a rule. If one is absent, for that person, you will not stop the studying. Are we clear with the technique? I'm telling about a lot of important techniques. Let me repeat again. Study partner is number one important thing other than the classes, and attending classes regularly is your priority. So 3 people study group, and you make rule, we'll discuss at least 3 days in a week, at least for like 2-3 hours. Okay. Now, if the 3 people are there, if one people is absent, the other 2 do not stop the studying. Clear? This will push the other to also, or not to miss any discussion things actually. For one person, you don't hamper your own routine. But now, if the study partner is two, if one is hampering the routine, is it possible for the another person to continue? I want your answer, guys. Please be participating in the comment section more, even though you find it boring, but it's very important participating. So if two-person study group, one is gone, the other study is getting hampered. Trust me, throughout the journey, I've been a teacher for MCLS, like it's
I
my
prefer listening
nine-year
to
crossed
my
10th.
recording. He's lecturing the
So many
PU,
complaints from the
sharpening the
study partner
PU.
all the time. Sir, I
I'm
lost my study partner. Do
yeah.
something
Like, but he's
that
still talking like
middle of the
right.
course,
They
someone lost
do
my
small
study
speed, and
partner
I'm
is
like
not
sick
active.
and tired. I want
So
a
this kind of
1.5 speed
things
and
are
like
very
you know.
common. So
Okay,
for a
how to
safe side, if
studying
you
it.
have three
What the
people,
people? Oh,
make
that's
a
the
three
subscriber
people
mà là
study
trả đó.
group,
I
WhatsApp group, make a three people's
preload nè. Now
uh,
I'm
like a
thinking you
video
need to
calling group
before
or
Wednesday
audio
update.
calling group. That would be really nice actually.
No, this is a live
Okay,
version.
someone's mic is on
Oh
because
yes, yes. They always.
let me, yeah, turned it off. Sorry. Yeah, now okay. Okay, are we clear? Yes, I turned up the microphone of someone's, so it is on. Yeah. Are we clear with the plan, guys? Very, very important tips, $1,000,000 tip. Like study partner, three people study group. If possible, you make multiple study groups. If you can go and study with a friend, if you have that access, go to a library and also invite a friend who lives nearby. If you are in Sydney, there's so many MC candidates we already have. I think many from Melbourne, Sydney, I mean, many places. We'll see that in future. But at this point, important, there's so many libraries in Melbourne, Sydney. Okay, so in that case, there's like a Westmead library. Melbourne has so many. Victoria, I think in the Central City Library, it's free. Very nice libraries, actually. You can go and you can study together. Then you can also have study partners or friends whom you can also discuss or chat online, actually. Talking is more faster than chatting. There's a thing we call, uh, we boys, we like talking, like sometimes over the online thing. Girls, they like chatting more actually. I'm not sure if this statement is correct or not, but what we saw actually, so far in my experience, actually, I mean, girls like they usually prefer, okay, quickly chatting so many things. We give voice message and this that, quickly finish up the things. All right, not applicable for all. This telling in general statistics actually. Okay, now try find your study partner. We will see that one once we clean the group. It will be fine actually. Yes. Okay, guys. So here is the thing. Here is our group. That's 59 and GIT inquiry zone. If you have any inquiry throughout the classes, you can also ask it there. Zoom links are already posted. So if you can see, it's given there. Okay. I usually always prefer coming to the class in time. I also prefer you the same. Some people has the habit of joining the class 15 minutes or 20 minutes late. But in the beginning, we always give some very important tip. Now you understand those people are just now joining, you know, is it their loss or is it their gain? They thought, okay, Dr. Sherry start the class after 15 minutes. He talks about some other things in first few minutes actually, but not getting those information might be a very, very big loss actually. So with that note, let's get started. Are you guys ready? Bring some positive energy. We're not hunting for study partner now, guys. You know, it will be washed away. Let's get started with the classes. That's most important. We'll start with the GIT 443 page number 443. And the chapter name is dyspepsia. Yes. So dyspepsia is the chapter name. If you have finding any difficulty, yes, let's proceed. So bring some positive energy. I want everyone to. So who wants to pass the MC? I know we have to ask people like this. So who wants to pass the MC? Now see, now you will see. So the more you will tell like a me, this means more chances. Yes. Okay. So let's go and start without any further delay, starting with the thing. esophagus, that is the GERD, right? So I'll take some help from the drawing part here. Now, say this is that stomach and the esophageal thing, and here is your issue. Our situation is GERD, which is called gastroesophageal reflux disease. And what is the main pathology? There's a relaxed sphincter. And when you have a relaxed sphincter, trust me, one thing happened. It's like a backflow of the acid reflux. We call it acid reflux. Now, this acid reflux will cause a major issue. What is that? That is the heartburn. Now, you can write something versus Acalasia. Acalasia never having any sort of heartburn because it is a tight sphincter. But GERD is a relaxed sphincter. This is very, very important, right? So tight sphincter and relaxed sphincter. About the study partner, guys, some people are still trying to find out. Please focus on the classes. We'll have a post in the Facebook to find your study partner. It will be more easy for you to share your details there. All right, guys? Great. Okay, let's focus. Now, next thing is coming. Can you tell more about the GERD? Can you tell me more about their features? In most cases, are they obese? In most cases, are they obese? The answer is a yes. I opened a gym recently. I do have some other endeavors. So being doctor, some people also ask a lot of things. So doctor, I have this problem. So with the obese, most of them has this acidity problem or reflux problem. I have night symptoms as well. Even yesterday someone was asking a night symptom. So have you tried two pillow? Yeah, I think it's better when I use two pillow. Very classic sign, isn't it, for GERD? Also, they have some bloating issue, like suddenly when they eat something coming up, they feel like that. So that's very classic for the GERD. Let's see what John Murtagh has to say. So you see a few features like heartburn, number one, because of relaxed sphincter acid reflux, nocturnal night symptom, and the bloating. These are some of the classic words for the GERD. A quick question is GERD investigation is required? Is GERD investigation is required actually? So most cases, answer in the first hand, we don't go for any investigation. Now, my question is here, are you going for a drug PPI first or going for an investigation first? Okay. AMC sometimes also ask you what is the next step. So they will give you an investigation. They will also give you a management. Now you have to pick up either the investigation or management. That's how the questions can be in MC. So answer here is a proton pump inhibitor first. If necessary, you can double the dose of the proton pump inhibitor. Now, in our first class, this is a compare and contrast. In our first class, we discussed about something that means another doubling the dose. Here, 20 to start. If necessary, you can make it 40. So if you remember, we like a 6 puff thing and making it 12 puff. Isn't it that a double the dose? Yeah. So many double the dose in throughout AMC. If anyone from the previous batch they know will come up in front of you. Now coming back to this treatment, PPI 2040, and of course lifestyle modification, weight reduction, and many more other things actually. Like if it is a kid having GERD, kid can also have GERD, with obese kid or anatomical issues. They can also have gastro-esophageal reflux disease. Now you cannot always give them the PPI, and their food is straightforward. Now, can you make any particular changes in their food? Now, that's my next question and very important 5-star MC question. What is the suggestion for the kids? Okay, so you give PPI like a solution or weight reduction or add thickener to the food. Now, kids are not taking spicy food, by the way, so it's not going, say, just a 1 year. So not giving any spicy food. Okay, avoid spicy food, but is it more important or add thickener to the food is more important? Answer, adding something or thick food. Add thickener to the food is number one. Then the next point might be important, like do not give the food at too late night actually. Then comes the point, maybe avoid spicy food as the kid progresses, kid grown up. So more spices in the food coming up actually. Okay, but usually 6 months, 8 months, usually we don't give spicy food actually. So yes, 2 hour or 3 hour prior to the sleep, the food is very, very important. But number one here is adding thickener to the food actually. This is a AMC question. So you can write this type of things and add in your John Murtagh will be very, very useful actually. So coming and seeing these things like bloating, heartburn, nocturnal, and few more other things are here given. In terms of the investigation of GERD or any esophageal disease, it is barium. I repeat, it is barium. Any sort of esophageal disease, it is barium. Now, here is the thing. Other than the barium, what else? How we confirm it actually? How we confirm it? Answer is a 24-hour pH monitoring. The answer is a 24-hour pH monitoring. All good? Great. Next, now this is the initial is a barium, then is a confirmatory. Then the question is coming, what about the endoscopy? Now that can be a question because you can see the indication of endoscopies are given. Before going into that one, what is the importance of doing endoscopy? You need to know in case of GERD case. The answer is some GERD cases are associated with dysphagia. This chapter is more about dyspepsia and dysphagia. But the question is dysphagia is the initial symptom for GERD? I repeat my question. Is dysphagia, difficulty in swallowing, is the initial symptom of GERD? No, the answer, it is a late symptom. In fact, quite late symptom. And actually a red flag symptom like a dysphagia, weight loss. These are red flag syndrome and alarming symptom. Alarm towards what? So GERD situation can lead to some cancer. The question is how? GERD situations can lead to cancers. Now this is getting complex. When you're having some heartburn issues, I hope you're using laptop. In mobile it might look smaller. There is some changes. So there will be a situation called Barrett's. Heard the name? Two-edged sword in pathology, Barrett's esophagus. Now can we say Barrett's esophagus is a pre-malignant condition? I hope you heard that. So from the Barrett's, there is a possibility of development of adenocarcinoma. Now that is the reason it is very, very important to know about the Barrett's actually. Barrett's esophagus. Okay. Once Barrett's esophagus developed, if you find it every 2 yearly, you need to do endoscopy. This is a very popular AMC question. 2 yearly endoscopy for the Barrett's. Very, very important. Also, a very, very popular, they'll ask you, give you a scenario of GERD, they'll ask you about the investigation. What you want to do next is give PPI starting with 20. Inconsistent or drug not working, in that case, PPI 40. This is also a very popular thing for the AMC. They'll also ask about a long-term management. Any guesses, guys? Is another MC question. So many questions from MC about this situation. For long-term lifestyle, of course, among the lifestyle, which one? So weight loss. Now, coming about the investigation, if your PPT fails, you actually need investigation. We start with barium initial. And how we confirm is confirmed by 24-hour pH monitoring. Is it clear to everyone? Now, the very important thing is coming in MC, other than this particular investigation, another very popular is doing endoscopy. So, GERD plus features of dysphagia. So dysphagia itself is I can draw a red flag. You can also draw a red flag. In that case, we go for what? We can go for a endoscopy. Is it clear now, everyone? This one is also very popular in the exam. All good? These are the things to understand. So GERD with features or red flag features, you need endoscopy. Initial is a barium. Further confirmation, 24-hour pH monitoring. These are the particular things. All good? Great. Please confirm in the comment section. Doctor, yeah. Please confirm in the comment section. You can see the recording later. Not a problem. It didn't get from the doctors. Others are not understanding. Last part. Okay, last part is GERD and dysphagia. Now, let me show you this part. Red flag and endoscopy. So, indication of endoscopy in GERD is a dysphagia. Can you see that 443 page? Just mark this line. Just mark it in your John Murtagh. This is the part I just mentioned there actually. Now clear? I hope it is clear. When you are doing an endoscopy, the last part, when you have the dysphagia, which is a red flag feature actually. Yes. Yes, someone compiled it. Very nice, Dr. Raiman. Yes, barium, 24 pH and complication well. Yeah. Yes, and there's lifestyle, of course. There's lifestyle in the next page, like a 2 pillow, food, avoid spicy food, smaller food. Oh, there's so many advices. Read it by yourself. Main highlight this line, reduce weight. This is highlight this line in 444 page, reduce weight. It's tested. Some drugs to be avoided because some drugs can cause, bloating features more. And here is the line. Please highlight this line in 444 page. Proton pump inhibitor. This part please highlight. This has been tested. Yes, double the dose. You can just write double the dose. Okay, is it clear now? I hope that's clear now. Can we start the Acalasia things? I hope this is yes. Another esophageal condition we were talking about is GERD. Other than the GERD, now it's a Acalasia. Okay. Okay. Yeah, there is a particular thickener. I mean, in child's cases, we also mention the management is a add thickener. Thickener. You can add a word Gaviscon if you want to remember. There's particular products available in Australia, Gaviscon. Okay, I hope this part is clear. Shall we move forward to Acalasia? Is my dear doctors familiar with Acalasia? Okay, boom. Okay, it looks complex. Let me clarify this particular part. All right. Now, did you remember the first part is related to a relaxed sphincter? Now, this part is a tight sphincter. As you can see, this part is a bit tight sphincter. So if tight sphincter, are you expecting acid reflux? Please answer me, guys. I guess not. If tight sphincter, are you expecting acid reflux? No, which is common in GERD. So here, no heartburn. No heartburn. Now, a very interesting thing about dysphagia, in case of Acalasia, there is a, dysphagia for what particular type of food? Dysphagia for liquid first. Have you heard this kind of time? Dysphagia for liquid. But often liquid is hard to detect. So they often come with the complaint of, I have problem with both solid liquid together. only dysphagia for solid, esophageal cancer, and the stricture. Okay, only dysphagia for solid, example, cancer and stricture. Dysphagia for liquid, if they're complaining, high chances, Acalasia. All good now? So this is a key thing to understand your question, because often your question will start a person 40-year coming with a dysphagia for liquid. Okay, so first liquid, then solid. All right, this is the thing. Now coming to the another part. What is that? If you see, this is like a um, cross section. If you remember in little histology here, mucosa, then there is a submucosa, muscularis layer. Do you remember from histology? I think many of us forget, but if you can remember mucosa, submucosa, there is a layer not in mucosa, in submucosa, there are myenteric plexus. And for our myenteric plexus, there is peristalsis. Am I right, guys? Because of the myenteric plexus, there is peristalsis. The thing is, in Acalasia particularly, these particular things can get affected, either congenitally or acquired by trypanosoma. Have you ever heard this name before? Trypanosoma in some parasitology books. Trypanosoma cruzi, bruzi, wrangeli, right? In a lot of things. They can certainly cause Chagas disease or Chagas disease, whatever you say. They have that ability to target the myenteric thing. And again, the same issue with peristalsis. And there will be dysphagia problem with liquid because of the peristalsis issues. Okay, great. So this is another additional thing you need to know. Now let's coming back to the important part is about the investigation. Now tell me one thing. Already I mentioned any esophageal condition, your initial investigation is barium. My next question is how you like to confirm, a case of Acalasia. We are discussing Acalasia investigation, very important for exam. So barium is the first thing. Then what's next is a manometry. Did I heard it right? Yes, manometry. So manometry is important for Acalasia to remember. Next thing coming, MC always ask you this kind of two things in diagnosis. They give you scenario, they ask you diagnosis. They give scenario, they ask you investigation, initial, next, best, this kind of thing. Next, if applicable, actually. Like lung cases we have seen, like X-ray, then there was CT scan, then confirmatory was biopsy. Here in these cases is mostly initial and confirmatory. There was no next here. Okay. Treatment. In terms of the treatment, coming to this particular process, in terms of the treatment, here we go. What is the initial and what is further next, or appropriate treatment? Often they use the word appropriate treatment for Acalasia. I repeat, discussing Acalasia, looking forward to treatment of Acalasia. Now let's go and find a little bit about the Acalasia. Yes, initial is always conservative. I agreed with you guys. Yes, please. Yeah, let me just show you in a second. Yeah, sorry, Acalasia is in the page of 452. We'll be also covering in between those things, so don't worry. Just if you want to just open up and mark it, it's esophageal motility problem. Drawing I have shown already, right? And dysphagia to liquid first, but many books say it's at the same time, both liquid and the solids. And now coming in terms of this thing, barium and the manometry. Speaking about the treatment, you see this, please take note in your John Murtagh 452 page. My page number is always displayed here, if you can see. So this is the whole page of John Murtagh. This is the current page actually. If you're using a laptop device or desktop, it's more easily visible. Now, coming to this part, conservative treatment. Then because it is tight, you need to make it dilator, or we use Heller's dilator. Okay, because tight, you can make it relax by Botox. MC often asks you what is the most effective. I repeat, most effective. So most effective is a surgery. It has a name. It is called myotomy. It is also a popular MC topic. What is the most effective treatment of Acalasia? I repeat, what is the most effective treatment of Acalasia? Answer is a myotomy. Even though, extra note here, it has high mortality rate. Remember, two areas surgeons don't like to operate. Even brain surgeon loves to operate the brain. But if you ask a general surgeon, one this esophageal area and another is a pancreatic area, they really don't like to operate. Right. Okay, that's the thing. So conservative, then comes the dilator. We call it Heller's dilator or Botox, and the surgery. Please write it down. I'm giving you 10-15 more seconds. And please write near to this. Most effective is a surgery, even though it carries high mortality. But it is true, it is most effective. 5 more seconds. Yes. And this is the Acalasia. Are we clear with the Acalasia, guys? Are we clear with Acalasia? Are we clear? Yeah, no problem. GRD done, Acalasia done. Yes. We do have a page 446. Dilator name is a Heller's dilator. And please make sure you come to the classes with a laptop device from next classes. Laptop or desktop, do not come with phone devices, iPhones, and this, that next time. Okay. It's a sometimes rules, regulation, protocols are important. Yes, extreme cases, if you really wanted to attend class, but unfortunately you had a duty came up, which is a different thing. You'll never get the best view when you are attending with a mobile. Okay. Barrett's esophagus, you see, already this particular line is a very special MC line, 2-yearly follow up with a endoscopy. Already it is mentioned. Okay. Peptic ulcer, we are coming with the stomach, so do not worry. One more esophageal condition. Let us finish. So we started with this. So, okay, esophagus, GIT, Acalasia, now coming is a cancer. Okay, remember one thing, if it's a major cancer, okay, it's important cancer, right, stomach. So you read about sometimes cancer risk factors, if that is possible actually. Like for a stomach cancer, what sort of risk factor is most highest? Okay, you'll find in esophageal cancer cases, some other risk factors are more. Okay, let me find the esophageal cancer one. I accidentally jumped into the stomach one. Sorry about that. It's 452. Sorry, guys. Esophageal cancer. Esophageal cancer. Stomach cancer is our upcoming topic. Great. And we highly recommend all the doctors to buy John Murtagh 8th edition hard copy. Most of the country it is available, or try buy from other country. You will need it eventually. So the more sooner you order, you will be gainer. Okay, coming back to this part. So esophageal cancer, did we mention about this thing that dysphagia to solid is related to esophageal cancer? Sometimes you need to remember some informations. Did I mention this line earlier? Dysphagia for solid. Now I'm giving you a few second time to mark it down. However things are given, I want you to mark in the same way. You need to have this habit, whichever I'm telling, following the instructions. So dysphagia for solid highlighted. It is slowly progressive, not too fast. Hiccup, hoarseness. So hoarseness is important. Sometimes in ENT we'll learn, they'll give you a scenario. Is it a esophageal cancer or is it a laryngeal cancer? So sometimes they come with a scenario like that. Learn it ENT, but remember hoarseness is a feature for esophageal cancer, lung cancer, laryngeal cancer. So they will test you down regarding this. Okay. This can be esophageal cancer can be related to GERD. We already learned. Now my question is, esophageal cancer is related to GERD. What esophageal cancer uh, can happen? I already mentioned this is a test of your recent memory, right? Those forget it. It means they have a short-term memory loss problem, right? Those are the Gajni people, actually. You know what is Gajni? It's a very famous movie. They every 15 minute, 20 minute, they forget things. So those of you already forgotten that GERD is related to adenocarcinoma. They are the Gajnis here, actually. Okay. Any Gajni here? I mean, I don't think so. They will tell. Okay. No worries. Okay. Thanks for being truthful. Yes. No problem. You will be like a Hulk very soon. Yes. No worries. Great. Now, in case of GERD, please remember it is related to adenocarcinoma. Extra note. Diagnosis. Already mentioned, any esophageal thing, it's a barium initially. But if you have a very visible sign symptom, what is the main test? Endoscopy again. Already we did endoscopy in case of GERD because there was red flag signs. Right. Esophageal cancer, any symptoms like a weight loss, dysphagia, these are red flag. You need endoscopy. Okay. So this is a popular thing in MC. Now, the most popular question in MC from esophageal cancer is coming up now. The question is, what is the most common type of esophageal cancer in the whole world? Two options, squamous cell carcinoma, adenocarcinoma. Whole world. Now, in the whole world, it is squamous cell carcinoma. Now, MC asks another different question. In Australia, which type of esophageal cancer is more common? Now, this answer is different. This is adenocarcinoma, very interesting, but this is adenocarcinoma. Now, I'm taking you to one of the part, help you guiding with a note about the esophageal cancers. Guys, are you enjoying the drawing? I'm not sure. Didn't take the review much, but do you like being drawn? Okay. Let's highlight 2/3. I'm clearing it now. 1/3. This is your esophagus. This is your esophagus. Esophagus is often divided into upper 2/3 and lower 1/3. Upper 2/3, the cancer is often squamous. Okay. Lower 1/3 is often adeno. Clear this thing? You can draw and remember this thing. Yes. Now, there's a formula to remember this thing. 1/3 A, B. Now, what does it really mean? 1/3 AB. 1/3 AB means lower 1/3 of esophagus. A for adeno. For adeno. What does this B means? Barrett's. Okay. So this time no short-term memory loss. Okay. So the 1/3 AB. Isn't it a nice one? So 1/3 AB, lower 1/3 of the esophagus, adenocarcinoma, and Barrett's. Now, you can also make a connection. Barrett's can be related to ZERD, right? Isn't it a nice connection? If you like this one, we have another nice one. BCS. In our country, the government cadre doctors go to the government services. It's called BCS, right? What is in your country? It is called, guys. I mean, if you are a doctor doing a government job, what is it called? In our country, it is a BCS. Isn't it Bangladesh Cadre Service? Anyways, I forget that. So the service commission type of thing, actually. Yeah, commission. Yes. Okay, someone said public service commission. The meaning is same. PSC. Okay, some people are meaning. Now, another nice mnemonic is here to remember. You must be remembering the lower 1/3 of the esophagus getting affected. So, in Barrett's, columnar replaces squamous. So normally it is squamous, but stomach lining is columnar, so which usually replaces the squamous. Is this good? No, it's not good actually. So this changing is a pre-malignant situation, chances of cancer. So in short, we remember BCS. This is not much important for EMC. This is just for memorizing purpose, but this is very important for you. And more important is 2-yearly follow-up via endoscopy. Are you clear, guys, this part? Are you clear this part? And also remember, MCC is squamous cell carcinoma, whole world, adeno, Australia. Now we are done. I'm trying to be more slow than early day, but I hope you are understanding more. But this is also a progress. As class progresses, you will understand things more. That is how the things are with us. Okay. Also, GIT is a little bit more interesting topic than respiratory system. Do you agree? Yeah. No, actually, class-wise things vary. GIT is a bit more interesting. Then you'll see my psychiatry is much more interesting. When you come to the psychiatry, so many stories about people. Okay. Now, as like any cancer, it is like a radio chemo, but first priority is a surgery. But often surgery is very difficult in esophageal cancer. But still, it depends on the grading. So what do we mean by the word palliative surgery, guys? That means most cases surgery is not possible, very difficult to approach in that case. No, 2-yearly endoscopy for the Barrett's esophagus till the cancer development. If cancer development is not about follow-up, you need treatment then, right? So coming to the surgery, palliative surgery means cancer probably has spread it already. So that's why you cannot do the regular surgery, palliative surgery that time. Okay, great. End stage surgery. Okay, guys. So are we clear about the esophageal thing? This so far, the things we started, are we a bit clear? These three, you will high likely to get one definitely question. If we cover the eosinophilic, there'll be more higher chance now. Now coming to the 453 page. Coming to 453 page, a little request. 453 page to open up. I'll show you MCQ. Let me make it a little bigger for you. No worries. 1 second. Just confirm if you can see the screen. I hope it is yes. Let's say adult. Let's say 40 years adult with a history of dysphagia. Main feature. After certain types of food lasting for few days. Okay, has taken certain type of food. Also history of asthma. That means the person has allergy. Remember, allergy, bhai. Allergies are like brothers. Now, interesting thing, endoscopy is revealing multiple constriction. What is the most likely diagnosis? There is previous allergic history, now history of dysphagia, long history, which has association with certain foods. Now, is it a GERD or is it a eosinophilic esophagitis? Now, final answer, this situation is a eosinophilic esophagitis. Yes, that's the answer because it has association with food. Now, coming to this one about eosinophilic esophagitis, it is an allergic disorder. It can have association with like asthma, which in our question it has been shown. And there can be some IgE level elevated because it's an allergy. Okay. What you can give is a fluticasone or steroid. This thing. One thing that is not written in John Murtagh, you need to write it down. That's why these classes are on the basis of AMC, we make classes. So here is a special line. Initially, it's always barium. Everyone agreed? Yes. Initially, it is always barium. And the confirmatory is a endoscopy here. And when you do endoscopy, it's a multiple constriction. And for more support, we also do IgE level. I hope that's clear. So initially we do, this particular thing, barium, then maybe next as a IgE level or initially IgE level, but further confirmation is endoscopy, multiple constriction. Then you can give steroid because it's allergic situation, or fluticasone or budesonide, this kind of thing. Okay, sorry, buscopan. Buscopan we can give. Special one line, you should write it down. I found somewhere fluorinated corticosteroid. One of the recall, I mean, sometimes you see, I mean, in respiratory theory class, some terms I mentioned, later it was useful during the recalls actually. So here is the thing, fluorinated corticosteroid, isn't it? Fluorinated corticosteroid. And of course, because it's esophageal situation, you will also give proton pump inhibitor. You will also give proton pump inhibitor. Question, is proton pump inhibitor is the mainstay of treatment of eosinophilic esophagitis, or is it most appropriate treatment of eosinophilic esophagitis? So the role of proton pump inhibitor is controversial in eosinophilic esophagitis, but usually we use it. That's how the thing is. So here is another important thing. Withdraw the offending food or the drug. So 70-hour elimination of the offending food. If you think a particular food is affecting it, you need to stop that one. Because that food allergy, as per the question, can cause the eosinophilia. Eosinophilia means the allergies. Yes. For more treatment, we need steroid. Is it clear, everyone? Eosinophilic esophagitis. Is it clear to everyone? Eosinophilic esophagitis. I hope that's a yes. I'm taking the screen for a second just to show you something. I think we do have a note on Zollinger-Ellison syndrome. Let me show you that. So if you attend classes attentively, most of the things you will find very well. Just taking a second. Okay. Let me share the screen now. Please confirm if you can see the screen. Now, if you go over note section, let's focus. Now, Zollinger-Ellison syndrome. We have to be a little faster now, guys. Have you heard this term before? Zollinger-Ellison syndrome. Of course, you do. I'll ask you one or quick question so that things become easy for you. In Zollinger-Ellison syndrome, do you think there is more acid is produced? What do you think, guys? Like a more HCl is produced? Most of you are answering as a yes. Now, the reason is why. Because of gastrinoma or gastrin producing. You must be knowing for esophageal, those particular cases, the hormone gastrin acts on the parietal cell, like these are the parietal cell. The gastrin acts on the parietal cell and help releasing more HCl. The gastrinoma is like a tumor, so more, gastrin produced, acting more on these parietal cells. They're very happy, looks like, and more HCl is produced from the parietal cell. Now the question is this more HCl your stomach is able to protect? This huge amount of HCl that is produced, is your stomach is good enough? The answer is no. Now what will happen? Multiple things will happen. Due to increased gastrin, there will be multiple ulcer. Can you correlate now, guys? There's like a too much acid here. So too much ulcer here. Related? Of course. You must be knowing gastrin is a hormone which helps in peristalsis. If you remember your long MBBS knowledge, gastrin is a hormone which helps in peristalsis. Now you have too much gastrin, too much peristalsis, too much peristalsis, too much diarrhea. Relatable? Yes. Now here's the situation. Diarrhea. And a special term, a question we have seen with AMC, Zollinger-Ellison syndrome has association with MEN1 association. What is MEN1, MEN2 association? I will teach in the endocrinology more actually. But for now, please remember, Zollinger-Ellison syndrome has association with MEN1 syndrome. Those of you who are not familiar with MEN1, you can Google it later, but in endocrine, I will teach that one. It's like association with one disease with another actually. Multiprine, yes, endocrine neoplasia. Here is the thing, gastrinoma, gastrin, more HCl, more ulcer. More ulcer. Now treatment, since this is a kind of like a cancer, we need chemotherapy. We take it from book, and also proton pump inhibitor to control the acids. Okay, so if I ask you a question that, therapy of choice for Zollinger-Ellison syndrome, your answer will be what? Your answer will be proton pump inhibitor, that is this one. Proton pump, not H2 blockers, proton pump inhibitor. So here are like some of the summary things. Multiple ulcer, ulcer resistant to therapy. So you are giving omeprazole, pantoprazole, this particular things. I'm sorry about that. You're giving omeprazole, pantoprazole, this kind of particular things. And let me turn off the file. Yeah, but it's not working. Also, there is diarrhea now. And peptic ulcer disease without H. pylori. We must be knowing, our next topic is coming, our peptic ulcer, which is related to H. pylori things. Okay. The note is already there in the note section. You can check it. Yeah. So this is for the Zollinger-Ellison syndrome. Zollinger-Ellison syndrome. Good question. PPI can induce diarrhea, but you are already in a, what should I say, in a deep sea. You understand my point? So you need to at least, you need also that PPI. It's an interesting question. I like it. Okay, we have another chart to follow. Nice to know things, but we also have seen recently this Boer has to coming in the exams actually. So first of all, I want you to take a picture of this part. Actually, you will not find it in our notes section. So one, two things which might not be present in note, but that's okay. I'll tell you in the classes. So this is one, because Boer haps have been recently started to coming a lot. The Boer haps actually. Question is Boer haps is a serious situation? Is Boer haps is a mild to moderate situation? Answer: Boer haps is a very serious situation. Boer haps is a severe life-threatening situation, often associated with like one part of the esophagus is teared up. Okay, so very dangerous. Esophageal wall ruptures in Mallory-Weiss membrane tears. So both are kind of dangerous. Both of them can be related to blood vomiting and this that. Okay, both of them can lead to shock feature and can be very dangerous. Mallory-Weiss, because there is too much blood vomiting, there will be dehydration. So you need to rehydrate first. So dehydration, need to rehydrate first. Also need to repair. Same with the Boer haps, you need to repair. Okay, medical emergency, urgent treatment is required. I'll show you something about the Boer haps which has been tested. Now this part get complicated because it is AMC. Things get sometimes a little complicated. Question is, what kind of investigation Boer haps needed? Okay, let's see a question first. Actually, okay, you might find it difficult, but as the time progresses, this kind of thing you will get used to. Sometimes we need to learn things question based actually. Okay. 40-year man after conference brain flooded, forced vomiting suddenly, pain in the sternum and feels like heart attack. Has got ischemic heart attack before in past. Okay. After resuscitation with the most appropriate step. So they put you some procedure name. They also put you some investigation name. So you get to see this thing in MC, investigation and also procedure together. Now the question is, are you going for a procedure here or are you going for an investigation here? But initial resuscitation is done. Yes, well done. Someone is mentioned. Trachea, we can see it's been shifted because it is a serious situation. Now, initial treatment, fluid, this, that, antibiotic, admission to intensive care, surgical repair is required. We need a lateral chest X-ray. I repeat, we need lateral chest X-ray to rule out this condition Boer haps, because and also there can be added pneumothorax too, because that's why the trachea is shifted. Okay, everyone, this is the trachea. This is supposed to be straight, but see this trachea, it goes into this line because of the pressure. So here is the thing, Boer haps can be related to pneumothorax. Since it is can be related to pneumothorax, it can be life-threatening. Now clear, everyone? And what chest X-ray we needed? Other than the regular X-ray, we also need lateral chest X-ray. This is a little bit specific demand. Okay, is it clear, everyone? Is this particular? This is a little difficult topic. Out of the other thing, this was a little difficult topic. I agreed. So I'm giving you 30 seconds to check this one and take a screenshot or do whatever. So please read this slide. I'm giving you a 30-second or minute. Okay, everyone. So we think we are done with the big section, the esophagus. Coming up topics are, you can see from the notes, stomach cancer, coming diarrhea. Okay, this particular thing. Zollinger-Ellison is kind of also related to that. Peptic ulcer disease, certainly. Peptic ulcer disease we need to finish. Coming up next is yes, peptic ulcer. Yes. Okay, so do you guys need a break now, or should we start uh, this peptic ulcer now? Let me know. Yeah, great. Yeah. Don't worry, things would be easy afterwards, actually. Yes. After esophagus, we need something in our esophagus, actually. Okay, let's go for a short break. Come back. Let's start, actually. Hello, everyone. Our inquiry zone is open now for GIT. If you have any questions during class time, a lot of things came up. Feel free to add those inquiries in the GIT inquiry zone for the live class doctors. Thank you so much. We're going for a 10-minute break now. everyone. So thank you so much for your patience. Let's get started. Okay, so those of you who came across, we are going to cover some of the topics. It's like just been copyrighted and the things. So we started. I mean, already we posted the overview. We are covering ZERD. Then there was Acalasia, this page. After that, few of the other things coming up like eosinophilic esophagitis 446, and then uh, again esophagitis, then stomach cancer will come up, and I'm going to start peptic ulcer. Please open up page number 446. Yes, great. I hope you all are ready to start this thing. As we mentioned, some of the risk factors are important regarding peptic ulcer or any of the diseases like a yeah. So let me just turn it off so that it becomes a little visible. Just 1 second, guys. I'm ready. Okay, so after the break, are you guys ready? All good. So 446 pages, 446, stomach peptic ulcer disease. So again, going to start with certain things. So this is, of course, the stomach and some of the risk factors to learn. Certain situations, certain risk factors for peptic ulcer. And here we go. There's a lot of things. Number one of them is H. pylori. Then comes stress, smoking, family history, blood groups. But drug history is also very important if you're taking NSAIDs or drug like steroid. Um, High flare-up of peptic ulcer disease can be very severe, by the way. Peptic ulcer can be very severe, by the way. Okay. Now, here is the thing about the peptic ulcer and this that. Uh, There's two types of ulcer which is not discussed in John Murtagh well, but uh, you should know it about it actually. One is a gastric ulcer and one is a duodenal ulcer actually. Now we do have, I think, a chart that can help you actually, peptic ulcer disease. Let me just show you how it looks like actually. So it's taking a second. Just bring something. Okay, this was a NSAID-induced ulcer, one-time tested topic. Okay, there was a line before getting into the peptic ulcer. Ulcer due to NSAID heals most effectively if, first of all, the offending agent is stopped. Okay, as we mentioned earlier, any number one thing which is causing it. Last day we learned Welder-Strom macroglobulinemia. Amoxicillin was the trigger. You need to stop the drug. So here you need to stop the NSAID first. For the further healing, you are using the omeprazole more. So NSAID-induced ulcer, stop the offending agent first. Then for healing, you can go for PPI. Okay, that's the basic first here. Great. Now showing you a chart that may help you. Yes. Let us take this chart here. It would be more easy for us to guide you. I hope it's visible more with the ulcer thing. Even in between the ulcer, the more common is duodenal ulcer. For duodenal ulcer, we use a very common word, hunger pain. Are you familiar with this term, hunger pain? Like means if you feel hungry, you started to hurt. So in empty stomach, it started to hurt you. Correct. So this is the hunger pain, which is opposite in case of gastric ulcer. When you eat, you feel pain. That is how the things are actually. Most of these cases, uh, the very common is a epigastric pain and point tenderness. There's another very important clinical examination, which is called the point tenderness actually. Okay. It is also universal for both of these cases. It may cause bleeding. Now the question is, which ulcer bleeds the most actually? Is it a gastric ulcer bleeds the most or duodenal ulcer bleeds the most? Let's see your thought about it actually. Now there's a two thing. One, perforation is more common in one of these cases. Second, duodenal, bleeding is more common in one of those cases actually. Okay. Now, what we prefer is perforation is MC, more common in duodenal ulcer, whereas bleeding, both can be present in both. I mean, perforation, these things both can be in both cases, but because of the left gastric artery is difficult to detect sometime, bleeding is quite a more common in gastric ulcer actually. Okay. Both of the ulcer cases, your choices of investigation is a endoscopy. In duodenal ulcer cases, hunger pain or pain in the empty stomach, whereas by eating it exacerbate in gastric ulcer. Treatment is lifestyle and treatment like PPI. Also, if there is a weight, smoking, and all these things are important. Point tenderness is more specific for duodenal ulcer, my dear. Duodenal point tenderness. Okay, normally I think we call it duodenal point tenderness. Sometimes we call it point tenderness as well. Actually, if you press, that particular part hurts actually. So we call it often point tenderness actually. Okay. There's many types of other anti-ulcers available, like not only so H2 blocker, PPI, prostaglandin. Okay, many more actually. Right. Are we clear with that particular part, guys? Are we clear with that particular duodenal gastral, which is, by the way, it is not present in John Murtagh. So I'm going to show this one again so that you can take a small picture of this particular part. Yeah, now we can take a picture of this particular part. This thing is not present in John Murtagh, so separately I had to bring it. So both of these cases, pharmacological treatment and also even surgical treatment available, by the way. My dear, what kind of pain and this that you can Google it, these are too basic, okay. You'll find it actually. All right, great. Okay, please take a picture. Okay, now going for further. Peptic ulcer disease, as you see, I highlighted H. pylori. I want you to highlight H. pylori. I want you to highlight NS site as well. Smoking is also smoking starting affect the prostaglandin. That is how it is started affecting. We found a recall question in past. It was a Cushing syndrome patient who also develops peptic ulcer. Okay. Now coming to the main point, your main investigation is endoscopy, but is it enough? The answer is no. We do have to rule out H. pylori, and for the H. pylori, there is a thing called urea breath test. And for the H. pylori, there is a thing called urea breath test. Very, very important AMC question. This urea breath test, is it, only for diagnostic purpose or also we do it to see the prognosis? So answer, it is for diagnosis and also the prognosis. This brings us to the point, for H. pylori, we give the treatment triple therapy, right, everyone? I think this is a very old MBBS knowledge. There is a thing called proton pump inhibitor eradication therapy. You see, there's a combination. There's a combination of this. This combination of treatment, whether working good or bad, you need to do endoscopy or you need to do urea breath test. Answer: urea breath test. I repeat, urea breath test. So it is diagnosis of H. pylori, also to see the prognosis of whether eradicated or not actually. If you want to also highlight, you can highlight this part. What is that? Yes, this particular, the pink color line, resistant to metronidazole and also nowadays clarithromycin. These are part of the triple therapy, is responsible for triple therapy not working. Heard about it? Yes. Right. So this is a major line, resistant to metronidazole. So if any NSAID is causing NSAID-induced ulcer, stop the NSAID and give PPI, like a omeprazole would be good. I'd like to ask something to the dear doctors. You heard about the peptic ulcer disease, H. pylori associated diseases. Let's see your test of your depth of knowledge. Can you mention about H. pylori associated disease? Okay, duodenal ulcer, gastric ulcer, we already discussed. Gastritis is a very good one, good choice. Maltoma, good. Similar maltoma, stomach cancer, okay. All right, good. Gastrinoma, Jess, well done. Maltoma you mentioned. A gastric lymphoma, well done. So a lot of things actually can happen because of this thing. Interestingly, none of you mentioned the most common one. Okay, I think I can see one doctor mention. Now, what is that? Non-ulcer. No, non-ulcer dyspepsia. Now, see, many of us sometimes also suffer dyspepsia features. Does it mean we all have peptic ulcer? Have you thought about it? I mean, some sort of discomfort we all have. We all are doctors. Stressful situation, even during MC, I think many will be flared up. But is that a peptic ulcer? No. Most cases it is functional dyspepsia or non-ulcer dyspepsia. Clear? And which is 60% among all everything. So it is very big in number, Yes. So non-ulcer dyspepsia, you will find it here somewhere. Yeah, you'll find it here somewhere. Non-ulcer dyspepsia, a simple proton pump inhibitor. Now coming to a very important 5-star topic. Of course, duodenal ulcer, gastric ulcer can bleed. What is the number one choice? They will give you like that. Number one choice is, first of all, I need to give IV fluid. I need to give IV fluid. Let me help you, as some doctors sometimes having trouble understanding. Say, if this is the stomach, and definitely it can bleed inside, right? We call it bleeding peptic ulcer disease. Now we are asking about what's next. The next is here, the most important. You need to give IV fluid. Now, whether IV fluid or given or not, how do you understand in question? They will mention you after resuscitation. Now, if your question is mentioning after resuscitation, what's next? I repeat, after resuscitation, what next? Means they have given you the IV fluid already. Now, this is the IV fluid. The most next important, most appropriate, they'll ask you in this way, most appropriate treatment for bleeding peptic ulcer. Now, I'll take you to John Murtagh for this section to mark injection adrenaline. Injection adrenaline, and of course, because the patient in a lot of stress, lot of issues going on, you need to give the IV omeprazole. Right, guys? So, injection adrenaline or heater pro, most cases injection adrenaline is given in the question. So, bleeding peptic ulcer, one line, injection adrenaline. Bleeding peptic ulcer, injection adrenaline. Clear, everyone? I hope it is a yes. And we already discussed non-ulcer dyspepsia. Already discussed non-ulcer dyspepsia. We already discussed H. pylori diagnosis and prognosis by urea breath test. And this can be resistant by because of metronidazole and clarithromycin getting resistant. Yes. So you can replace with tetracycline and amoxicillin instant. Okay, so this part is technically done. Now this brings us to, after peptic ulcer, this brings us to, yes, if someone asks a nice question, if resuscitation is not given, that means IV fluid. If they are offering you IV fluid, then you can pick up the IV fluid first, actually. Great. Now, coming to the stomach cancer, and stomach cancer has a lot of risk, right? Stomach cancer certainly has a lot of risk. Sometimes a interesting question is asked among the clinical features, like stomach cancer have discomfort with food, heaviness, then there will be weight loss. Okay, then there can be vomiting. Dysphagia can be a late sign, by the way. Okay, or fullness is often quite a common. The number one is the main parameter, or most of the stomach cancer, which is eventually evident, is a weight loss. Okay, everyone. So number one feature for stomach cancer is weight loss. Clear, everyone? And this is already tested in exam 1. So for stomach cancer, this tested some risk factors here, age. So the question will be given like a not a 25-year question will be given like a 65-year or 55 years, right, with a cancer. And some of the other features. Have you heard about this thing? Eating more smoked food like sushis and this, that is the reason areas like Japan probably has more stomach cancer than others. Have you heard things like this before? Maybe yes. Or maybe barbecue. I think we all eat barbecue a lot nowadays, right? It is also seen if we skip the genetic part. Okay, if we skip the genetic part, uh, the vegetarian probably has a less uh, stomach cancers. Agreed? If we skip the uh, family part, so less chances in that case, actually. Right. So you might find mass, so anorexia, malaise, dyspepsia, weight loss, chances of stomach cancer. One thing I want to highlight, is there any specific lymph node you want to examine? As I think you all are clinicians, so I think it's a specific question. Any particular lymph node? Yes. So left supraclavicular lymph node. I repeat, left varicose striate, left supraclavicular lymph node is often a yes. So this is the thing. So even in these cases, because it is related to stomach, so initially is always barium, but eventually we need endoscopy and biopsy. We eventually need endoscopy and the biopsy. What is the treatment for stomach cancer? Wherever possible, we can try doing surgery. But most cases, surgery may not be possible. But wherever surgery is possible, surgical excision. Depends on the staging is the best answer. I agreed. A quick question. The prognosis in general about stomach cancer, is it good? Always try read the 5-year survival. But for your general knowledge, I'm telling actually. Because patient will ask you, doctor, what's my chances? So prognosis is not good. How about stomach cancer? Again, bad. All right, same bad. Stomach cancer also has a bad prognosis. Name a cancer with a good prognosis, guys. Name a cancer with good morphs. Of course, depends on staging, first of all. I guess not follicular, papillary carcinoma of the thyroid, and some of the testicular cancers actually. Prostate cancer actually depends on the type, dear doctors. Hodgkin also has a good prognosis, by the way. Okay. Let's coming to the intestinal area a little bit more. Okay. So here is a thing. We are at page number 417 page. I'm giving you some time to go to the 417. We're studying the intestinal areas. Okay. 417. So from this intestinal area, so lower GIT bleeding, GIT lower is important than malabsorption. Okay. Diverticular disease and angiodysplasia and hemorrhoids, these are part of like a surgical topic, so we will not discuss those here actually. Okay. Let's find out some other. Now, important some of the things for exam is a celiac disease. When you read about celiac disease, you should know about the cystic fibrosis a bit. Cystic fibrosis is our pediatric topic, even though. Okay. Since intestine is in trouble or diseased, in that case, it can lead to diarrhea. And diarrhea caused by multiple microorganisms is very, very important for the exam. Like typhoid can also affect, even gives ciprofloxacin, like this as an example. Then comes the big one, inflammatory bowel disease. This is actually like a 5-star here, and the celiac one, these are the 2 5-star here actually, and lower GIT bleed. And inflammatory bowel disease, similar another like this, which has a psychiatric feature, IBS, alternative constipation and the diarrhea, right? Which is also uh, popular actually. Okay. So let's get started, guys. Are you guys ready? Like, so first of all, 417, guys, I'm losing energy. So you guys need to bring some energy in the classroom by saying, okay, uh, let's go or something like that. Sometimes, yes, it's good to encourage each other actually. Okay. So malabsorption, like a can be because of lot of things, like see highlighted ones I want you to highlight. As I repeat, highlighted ones I want you to highlight because I've seen similarities in questions. First of all, Crohn's, lactose intolerance, like Crohn's disease, like that is IBD, Giardia. Okay. Post-surgical, which is our surgical topic as a dumping syndrome. There's a lot of malabsorption or some dump features out there. And some of the things like cystic fibrosis can lead to malabsorption, but mostly common in kids. And of course, pancreas, because pancreas has a exocrine and endocrine secretion. Did you know this information? Exocrine secretion of pancreas is related to digestion. I'm sure you know that. So if pancreas get affected, your digestion get affected. And last but not the least, Zollinger-Ellison syndrome we have discussed already. Now coming by one, before going into celiac lactose intolerance, a time for some truth. Okay. Do you know that almost 60 to 70% of Asian are having a certain level of lactose intolerance? Even I myself have a little bit. See, if I drink a bowl of milk, 1 glass of milk, or maybe two, nothing really will happen. But if I drink it too much, I mean, I may have to go to toilet in that case. Not an uncommon scenario. I think it's applicable for Asians a lot, actually. Especially remember, like for us, Eid day, during Eid, I think we go to so many homes. And after some time, we start feeling something because so many milk products. sweets, and many things out there. So, eventually lead us to come to home or in the same home, whatever it is, we might need a toilet. So that's very classic lactose intolerance. So main suggestion, try to avoid lactose more related food. Do you know nowadays there's a very big number of um, things are sold in the super shop. Have you seen lactose free milk? If you're already in Australia, you don't have to worry at all because you have lactose free milk now. Trust me, it's quite good. Tastes good as well. Actually, I don't feel any tummy trouble. Yeah, when I drink the lactose, but do not buy those maybe from home countries. In our countries, some I found expired as well. Yes. Anyway, so lactose intolerance, try avoid the too much lactose. Okay, coming to another important before going to the celiac, because these are smaller thing. Have you ever heard about a parasitic disease name, you know, like called a badminton shaped parasite? Anyone remember? Okay, and if you're talking about Australia, some places we call it aborigine. Like if this is the Australia, like a part, Adelaide, Darwin, middle part has lot of local people, Aboriginal people, and Aboriginal people often they get diseases so often because hygiene is not maintained. Even though when you go to Sydney, Melbourne, you might think, oh my God, where am I now? Actually, I mean, this is so developed. But if you go inside, you might find some areas, oh my God, these people exist as well. Okay, they might not have connection with real world, some areas. All right. Now, this is the part, Aborigine, they get a lot of diseases like alcoholic diseases, heart diseases, diabetes, because of lack of screening. One of the diseases is also very common. They get diarrhea, and most often this diarrhea because of what? Parasitic infection like Giardia, and they'll be presenting diarrhea for more than 2 weeks. Okay, so the question is, what treatment you need to give here? The simple answer is a metronidazole. Very simple answer is a metronidazole. And this particular type of diarrhea is very much foul, smelly diarrhea. It's another thing about the Giardia, very much foul, smelly diarrhea. And it floats on the toilet. I don't want to get into that particular part. Yes. So it's mostly parasitic infection. Also, if you travel to some of the areas, you might also get parasitic infection like Giardia. Okay, coming to this part. So lactose, Giardia. As we mentioned, post-surgical dumping syndrome, which will be I will teach you guys in the surgery class, so don't worry. Let's skip that one for now. But imagine a part of your colon is not there, intestine is not there. Certainly, the absorption will not be similar like as before. Do you agree? Yes. Okay. Taking a second time. Okay, I'm just taking 1 second of time, please. Okay, please open page number 417 for celiac disease. Yes, please. Okay. 417 for celiac. I think we're in the same page. Okay, no problem. We have some bullet points here for the tribes. You see, acute diarrhea, pain, colicky pain, and vomiting, gastro, blood and mucus. It's a inflammatory bowel disease. Again, inflammatory bowel disease, more systemic presentation, eye features, Crohn's, pale bulky stool, malabsorption. Okay, then celiac disease, weight loss, fatigue. We'll talk about more about celiac. Failure to thrive, special line, please highlight this line. Failure to thrive, repeated respiratory tract infection, cystic fibrosis. You see, along with weight loss feature and constipation and bowel habit recently changes, altered bowel habits, colorectal carcinoma. For elderly, very common fecal impaction. Often you can see this thing in X-ray very commonly, and there will be abdominal pain, of course. Often they get admitted in emergency because fecal impaction. A very important, pseudomembranous colitis. Can anyone tell me what is the cause of pseudomembranous colitis? Any guesses? It is because of some particular microorganism, Clostridium difficile. But the question is, Clostridium difficile can lead to, you need to give some antibiotic for that microorganism, like amoxicillin. Okay, so you need to give like a amoxicillin. That amoxicillin eventually can turn into this situation, pseudomembranous colitis. Now, how do you treat pseudomembranous colitis? How do you treat pseudomembranous colitis? First answer is a metronidazole. If metronidazole not working, vancomycin. Vanco, by the way, can be available oral or IV, both as well. Okay, so metro, then vanco for pseudomembranous colitis, like a antibiotic associated diarrhea. Heard this name before? I'm sure you do. Antibiotic associated diarrhea. Yeah, new one is also available. Fidamycin, new one also available. And last but not the least, irritable bowel syndrome. Irritable bowel syndrome, there will be like a alternative constipation and diarrheas. Alternative constipation and the diarrheas. That is called the irritable bowel syndrome. Often they are female and they're also having some sort of psychiatric features. Actually, in case of irritable bowel syndrome, it is seen like a 2:1. I mean, more in female than male actually. Okay, so this is the in general things about the malabsorption. Now coming into the more detailing about the celiac disease. Now, if you see, starting in that way, if you have been through a lot of restaurants in Australia or even abroad, or even in our country nowadays, there's something written gluten-free diet, gluten-free food, gluten-free this, gluten-free that. Have you seen this thing? I'm sure many of you do. It's also popular thing for branding your restaurants, like a okay gluten-free available, and people came in and serve gluten-free and this that available. Okay, I mean looking more posh. Anyways, so in case of celiac disease, I repeat, in case of celiac disease, there's a particular things. For celiac disease, there are some particular things. Let me take a picture here. All right. Okay. So about celiac disease, let me try to draw something. This is, we can say, villi. Speaking about our intestine, there are villi. Villi has a lot of, the sucker machine, so it helps absorbing. The question is, the same situation, celiac disease, is it the same villi as like this normal villi? The answer is a no. This villi is kind of like a slender or short, abnormal. Now the question, do you think is it the same absorption as before? Answer is a no. So this leads to um, this particular situation to happen. Now, question is how this is happening. Um, is celiac disease an autoimmune disease? Quick question. Is it an autoimmune disease? Yes. Now, if we eat certain kind of food like a brow, barley, rye, oat, wheat, brow, then this particular area can get inflamed. Now, did you know this thing? Certain food, I mean, we read about so many things, but honestly speaking, even we as a doctor don't read about diet, nutrition, and food that much. There's certain food that can lead to a lot of inflammation with your bowel, with your body. Is that true? Let's see your ideas. Certain foods can lead to a lot of inflammation of your tummy, bowel, even in your body. So those people are more into gym and this, that. They follow particular things like, okay, diet with no inflammation, like say, uh, boiled vegetable, saute vegetable. Uh, they have antioxidant and least inflammation. But if you are eating like a shish kebab or the most spicy one, it's not only for the tummy but for the body, sometimes holding more water, because there's a lot of salt and testing salt and many things you don't know what spices out there actually. Some of you may be liking, make it more spicy. Okay. Now, how many of you like spicy? I mean, some people intentionally make it, okay, give some more naga. Nowadays, there's a special spice. Oh, please give more naga or this, that. I cannot eat without naga, so so it's already you are in so much inflammation. Anyways, technically, be careful. I mean, your tummy does not get hurt at some point, actually. But I just hope you are resistant with that. Now, coming to the point, when you eat these particular things, because of this particular, they're particularly not like too inflammatory, but because of this typing of celiac, barley, rice, oat, wheat, this tummy get inflamed. But originally they are not inflammatory food. Now the situation is like that. So less absorption. Okay, that means more diarrhea. Now, is it one of the first thing that celiac disease will have malabsorption? Celiac disease will have some more diarrhea. Someone is mentioning chui jhal. Yeah, I have horrible feeling after, my tummy is not up to the mark already, but not staying in Bangladesh. And that was, I think, quite a spicy one, actually. Yeah. And also, yeah, there's like a particular type of spice in our country. Also, some types of, the noodles. Intentionally, some people intentionally try that noodles, actually. I don't know. There's some noodles out there. One of the friend asked me, okay, that really good chow mein. Oh, really? Okay. Then went. And after that, I have also allergy sometimes with too much spices. The situation was real bad. I had to take like antihistamine, this, that. Horrible experience. Now, coming to the point of celiac disease, because of this particular food, tummy got inflamed and malabsorption and leading to diarrhea. Celiac disease is very common in Australia, but lot of people are still asymptomatic, by the way. Okay, this is important. So they can get fatigue, they can get diarrhea, they can get vitamin deficiencies, and so many other things. Okay, and that particular villi is known as subtotal villus atrophy. Let me make it bigger. It is known as subtotal villus atrophy. The question is coming. Uh, very, very important. They'll give you a question and a scenario. Sometimes you have to make a diagnosis. Either it's a celiac or either it's a cystic fibrosis. Now, cystic fibrosis, there will be failure to thrive, or repeated respiratory tract infection, and many of the other features which I will teach you in future will be present, which may not be present in a celiac. Coming to celiac, another very important for AMC is their investigation. Now, what is the initial, what is next, and what is best? Let's highlight all of them has been tested in AMC. Initial for celiac, next for celiac, best you can see it is a biopsy. We can see that already. Small bowel biopsy or duodenal biopsy. What about the initial? Anti-transglutaminous. Anti-transglutaminous. What about next? Anti-endomysial antibody. So both are like blood test, and the confirmatory is a biopsy. All good, guys? So I'm having 1 minute break. Just please look around and try to read this part. Okay, sorry guys for taking some time. Yes. So we were talking about celiac disease, one of the disease which is quite common in Australia. And as we mentioned, there's certain things like, intolerance to brow, means barley, rye, oat, and wheat. These are the particular features. And because of this, our like intestine get affected, right? So, and the intestine has become shortened, and that's why there is diarrhea. Intestine shortened, that's why it is diarrhea, along with many other features like fatigue. Because of the vitamin deficiency, there will be particular symptoms for vitamin. Now the question was like, the most important part for the exam is what are the investigations. So first thing was anti-transglutaminase, which is a blood test, simple anti-endomysial antibody testing, another blood test, and last but not the least, small bowel biopsy. Okay, this is the most popular for the exam AMC, small bowel biopsy. Are we clear, guys, about this thing? Are we clear so far? All good? Fantastic. You guys are amazing. Okay, so let's see and find out what this book John Murtagh has to tell. You see celiac disease. In celiac disease, as you see, uh, many Australian patients are asymptomatic. That's why when you go to a lot of restaurants, you will find gluten-free diet, right? Gluten-free. Because if you eat gluten, that is the barley, rye, oat, and wheat. It is four components. If it is there, there will be flare up because those are a bit inflammatory to the tummy uh, for celiac people, not for regular people, and they will get affected. Now, last thing, uh, treatment, which is withdrawing of the offending agent. Here, the offending agent is the food. So you need to stop those particular food, right? So brow control, the brow type of food you need to control. Now, second step of treatment is what? If it's not working or your situation has become more serious, then what? In that case, your treatment is only one thing, which is also used in some sort of like a advanced case of leprosy. What is that? If you can see here, have you heard about the drug name Dapson? Yes, well done if you know the name. So you can use the Dapson. So first, number one, gluten-free diet. Second, Dapson. Yeah, but we do also use it for here. We also added a new point has been added, give pneumococcal vaccine. It has been seen that celiac people also prone to develop pneumonia. I have a small request to all of you. Uh, if you have any elderly person at your home, please make sure uh, you ask them to take a vaccine for the pneumonia. It's like pneumovax is very one of the common. It is true, we as a doctor, we are not good as a patient. Neither we are very good with the family members, right? So since you guys sometimes follow me or listen to the words, so please do this thing. Another thing I will tell in the gynae that, especially for our ladies, like, now how many of you have taken the like cervical cancer vaccine? That I'm sure I'll see no many. I mean, yes, no. I mean, see, so many. Still, many are doctors, but many never have taken that one. You can still take it. There's no problem. Okay. Yeah. Right. Gardasil. Yeah. The vaccine name is Gardasil. For all young women out there in our classes, make sure you get the Gardasil vaccine in next coming 1-2 weeks. Okay. Great. Before leaving this thing, one special thing for the AMC, one-time tested topic. Someone asked when we give Dapson, doctor, when step up management, when controlling the brow is not enough, still symptom persist, then we give the drug Dapson. I hope that's clear to you. Next, special one for MC, another celiac disease plus skin lesion. Celiac disease plus skin lesion. Now, I'm trying to show you someone's picture. I'm not sure you are familiar or not. Yes. Yes. Please try. I'm not sure you have seen him or not in some movies. A favorite character for many of us. Yes. Yes, Pirates of the Caribbean. Anyways, this is a fun thing. Johnny Depp has glue on his armpits. It's a funny way to remember. The question was celiac disease associated with extreme itching. Okay. Celiac disease associated with extreme itching situation. So this is dermatitis herpetiformis. Dermatitis herpetiformis. So you see, gluten-free diet, step up management, DAPS. All good? I think we're getting into one of our end section before inflammatory bowel disease. That is the some of the diarrhea related thing. Is celiac disease is clear? I hope so. It is enough information for you to clarify. Okay, traveler's diarrhea. Let's see. I'll just ask one question. When we go to travel, we might get diarrhea. And what microorganism is responsible for that? I'm sure all of us, we have read in MBBS, that is the E. coli. Okay, that is E. coli. Traveler's diarrhea, we have seen this question coming. It is bacterial, not viral. Okay. Upcoming topic is the inflammatory bowel disease, that is Crohn's disease and ulcerative colitis, very popular in MC. Before that, let's patch up this part. Any diarrhea cases, like a multiple incidences going to the toilet, loose motion we call it, you need to secure the fluid level first. We all know that. Fluid level first. Okay. Next, another thing is we need to see is here which particular microorganism responsible for diarrhea. You need to give certain type of treatment. So this is a part I'm not really going to teach you because you need to memorize this part. So treatment, antimicrobial drugs, we have finished in past in microbiology. You see Shigella, this is the drug. Giardia we finished today, which is Metro. Special Salmonella, Cipro, page number 423, John Murtagh book. Ciprofloxacin for Salmonella. The Salmonella is something when you eat and immediately you get diarrhea. So either it's a Salmonella or either it's a Bacillus cereus. Okay, it's always like incubation period, very short. Immediately after eating, you got diarrhea, either Bacillus cereus, either Salmonella. Always remember that. Now coming Campylobacter, azithro. Amoebiasis again, Metro, and another new name came up. Typhoid, azithro is fine. Ceftriaxone is also, Cipro is also okay. Cholera nowadays does not exist much, but azithromycin again. Okay, so please remember these particular things. And sign of dehydration was more part of the pediatrics, nothing really to worry. Sign of dehydration, I will show you a chart, but if you just Google it, what are the sign of dehydration, mild, moderate, severe dehydration, just check it one time. Okay, because based on the mild, moderate, and severe dehydration, your treatment pattern can change. Correct? Great. This particular drug name, not all, the marked one to remember, guys. I'm sure most of you already know about these drugs. Just one to maybe new here. Okay, last but not the least, inflammatory bowel disease actually. Okay, I'm holding here for a second. Let me bring something for you. That is the IBD. Okay, this part is okay. So I'm scrolling the slides and bringing something for you. Okay, can you tell me? So this is still we are part in the intestine. So ulcerative and Crohn's disease. Ulcerative colitis and Crohn's disease actually. Mostly diarrhea, blood, and mucus. Right? Diarrhea plus blood in the stool plus mucus and lot of systemic feature. Is it only GIT or there are extra GIT feature, guys? What do you think? So there will be a lot of extra GIT features as well, right? So if you just go down and see the clinical features, we do have a note in our note section about IBD. You'll find these things. So here you go, like a extra GIT features. If you can remember, it's fine. Nice to know to remember the extra GIT features. But abdominal pain, diarrhea, mucus, these are common. Since inflammatory word is there, there will be fever, that particular word. Right. Now coming to this part about ulcerative colitis. One interesting thing about ulcerative colitis and Crohn's, if we remember the histology and lot of 4 layers, in ulcerative colitis only first 2 layers are affected. But if you see the Crohn's disease, among the 4 layers, all 4 layers are kind of effective. Now, the chances are more of having total obstruction is more in which one? It's a basic next question to all of you. Ulcerative colitis or Crohn's disease has more chances of complications in terms of obstruction. Yes, please. So answer is a Crohn's disease is winner here, having more chances of obstruction. I've been a teacher for many years, and once I was teaching in China. So I used to be strict about, smoking things, about the smokers. So some of the smokers' cigarette packet I used to seize as well that particular time. Now, thing happened, there was a drama and play, and in that drama, they make a fun of me. Okay, I mean it's a constructive, funny one. Why this name is coming, and they made, yes, did you know smoking is healthy? Why Dr. Shahriar has told smoking is healthy? I was also sitting, and my dean is also looking at me. Did you mention? No, not really. Maybe the twist is coming. Now they find out smoking is responsible for 400, 500, and many more diseases directly. But there's only good news for 3 conditions. One is ulcerative colitis, one is a Parkinson's disease, and one is a Lewy body disease. So little some neurological, and one of this GIT disease has less chances, has including Alzheimer's. 3 or 4 diseases. All right. So anyways, that's a fun thing out there actually. So some of them make a fun. Yeah, oh, you're there, Adnan. Yes, nice. Good to see you. Great. So nice one. And they made it into drama that, smoking is healthy. The motto was smoking was healthy actually, So they found only 4 diseases actually. Anyways, remember that one. Maybe someday you are teaching someone and you can mention, okay, tell me 3 diseases. I mean, why smoking is beneficial or may not happen. That's okay. Alzheimer's is not bad. Coming to the more points, pseudo polyp is another thing. Pseudo polyp. Let me show you something about the pseudo polyp. If you see this particular picture now, yeah. Now this is normal. This is Crohn's because all 4 layers involved, so less space, so more chance of obstruction. And this is ulcerative colitis, more ulcers, so more painful. And you can see the views. There's a pseudopolyps, more with the ulcerative colitis. Crohn's disease, cobblestone appearance actually. Okay, so coming to this particular part again. So pseudopolyp more in ulcerative and thickening and narrow lumen related to Crohn's, and complications more related to Crohn's, and some extra GIT features to remember. Now coming to after the clinical features. So what kind of questions are tested from inflammatory bowel disease? They'll give you a scenario, and from that scenario you have to make a diagnosis. This is first of all. Then some of the cases they'll ask you for the treatment. The treatment is very important regarding AMC. You need to remember as initial, as a next, as like more appropriate. 3 stages of treatment is definitely very important to remember. Now, what are those? And you can make a diagnosis, of course, by sigmoidoscopy, right, or colonoscopy, right? Now, coming to John Murtagh part now, I want you to highlight these particular lines. Recurrent attack of loose stool, blood, and special one line I want you to highlight. This is important for exam, one-time tested topic. Area of friable mucosa. Can you see that? This is exactly line tested, last year. Area of friable mucosa, which is related to Crohn's. See, this is not present in this book, but we need to know it, right? So area of friable mucosa. And if you come to the Crohn's, okay, one more thing to highlight from the ulcerative, increased risk of cancer, and of course bloody diarrhea. Whereas in Crohn's disease, blood and mucus is more than ulcerative colitis. See, blood and mucus is common in both, but with the mucus more in Crohn's disease. With complication, more in Crohn's disease. Yes, note, lecture, and of course recall and your own practice will be necessary for passing the MC. Okay. Of course, abdominal pain, cobblestone appearance, I have shown just now, and we're heading towards the treatment now. Now, some stages of treatment I mentioned. What is the first one, guys? I have mentioned initial. So initial treatment is a sulfasalazine, and this is also one of the initial and mainstay. Sulfasalazine. Clear, everyone? Alongside, you can also sometimes give painkiller. That's also okay. You can also see azathioprine in severe cases. Can you see that? Azathioprine in more serious cases. And there is a provision of surgery. Now, question is steroid is the mainstay of treatment, or is steroid stop the disease progressing? Please understand the question. Is giving steroid prevent disease progressing, or is it better when there's an acute flare-up? Since this is an autoimmune disease, for any autoimmune disease, the method is it prevents acute flare-up. Every autoimmune disease, not only this situation, many other situations for acute cases. So this is a treatment for acute, not for disease progression. For example, someday I will teach you in neurology, multiple sclerosis. In multiple sclerosis, we also use corticosteroid or steroid. But it is not for stopping the disease progression, but for the acute flare-up. Clear? Compare and contrast. Compare and contrast. Okay, so everyone understood about ulcerative colitis and Crohn's? Everyone, this was the chart. Everyone understood about the ulcerative colitis and Crohn's? Holding here again, if you want to take a screenshot, that's okay. So in general, difference, in general, investigation, which is the sigmoidoscopy, colonoscopy, in general, treatment. Initially, sulfasalazine, acute flare-up steroid, severe cases azathioprine, everything fails, surgery. I repeat, everything fails, surgery. Okay, summary, initial treatment, sulfasalazine. Okay, acute case, acute flare-up. Patient presents with symptoms right now, like abdominal pain, blood, mucus, then you need to give steroid. Okay, right. And finally, azathioprine. Someone once requested to see the picture of cobblestone appearance. This was the picture of cobblestone appearance for Crohn's disease. Ulcerative colitis has pseudopolyp type of features. This part is little complicated, I know, because first you need to memorize some of the points for ulcerative and Crohn's disease. This chart will help you memorizing that particular parts. But think in that way, this is bigger lumen, this is more narrow lumen. So narrow lumen has more chances of complication. Mainstay or more appropriate treatment is a sulfasalazine, honestly. Okay, sulfasalazine main treatment here actually. They already mentioned in John Murtagh, it is the mainstay of treatment. Mainly, yes. The sulfasalazine mainstay. Then if situation gets bad, then azathioprine. Okay. Last but not the least, guys, inflammatory bowel syndrome, IBS. IBS, we also have a note in our note section. So I'm just telling there will be alternative diarrhea and constipation. Interesting, right? Alternative issues with the diarrhea and constipation in these cases. So IBS at a glance, you can see alternative diarrhea and constipation. Sometimes they came with a diarrhea phase. Sometimes they came with a constipation phase in IBS. So lifestyle modification, because of sometimes they have psychiatric symptom. So did you know this information that in IBS or inflammatory bowel syndrome cases, it is some cases required to give SSRI or some sort of amitriptyline type of drugs? Have you heard this kind of scenarios? Maybe yes. All right. Okay, let me show you. So in terms of symptom, have a look. One interesting thing, everyone's IBS experiences is quite unique. Some people come with diarrhea, some people come with some other experiences. Okay. They can suffer for days to weeks, many times. For some, it can be chronic. So you see, it's a disease which varies from person to person. But some of the common features like pain, bloating, gas, diarrhea, and constipation. These are more common for the IBS cases. I wanted to show you in general, which is not present in John Murtagh. In general, these all drugs can be used. I took it from Oxford Handbook of Medicine. So if you see if it's a constipation phase of uh, IBS, you give drugs to prevent constipation. If it's diarrhea, you give something to stop diarrhea. And in general, if you see antidepressants has been used, you see fluoxetine, which is a SSRI. Now clear? So fluoxetine or amitriptyline, this drug's provision is also mentioned here. Okay. There is shown not directly dominant, but some association has been shown. Okay. Some doctor asks, is it a familial? Association has been seen in the families, but not a autosomal dominant. Clear now? Okay. But these are in general some of the drug names for the IBS. Okay. So irritable bowel syndrome. See, young women, most cases 21 to 40 years. They are more affected. Pain, changing in bowel habits, often precipitated by eating. So you can have a look. It's a nice to know topic, by the way, for AMC. Antibiotic used when if you have the features of diarrhea or if you have a blood culture or stool culture positive. Okay, that time you can go for antibiotics. Yeah, you see they have written so many things because it's a common ground for practice for the GPs. Yeah. And of course, dear doctors, about lower GIT bleeding related to diverticular disease and angiodysplasia, I'll be teaching you in the surgery, which I have mentioned, which is the lower GIT bleeding actually. Okay, so in general, I'm just giving you idea lower GIT bleeding. You know, if this is your stomach, then it comes with the intestine. Do you know what part separated upper GIT bleeding and lower GIT bleeding? There's a ligament called ligament of Tace. So any bleeding from esophagus, any bleeding from this stomach, any bleeding from upper part of intestine is related to upper GIT bleeding. Any bleeding from this is called ligament of Tace. Ligament of Tace. Any bleeding like a colonic, this particular part, sigmoid, and this third, even rectum, anal canal, all this part bleeding is related to lower GIT bleeding. The commonly missed guided things, number one cause. Number one cause is a people say hemorrhoids or piles. but actually it is diverticulosis. Second common is a angiodysplasia. Third is a hemorrhoids. Okay, then coming anal fissure, many other things, many situations. These are our surgical topics, guys. All right. So we don't want to prolong too much long. I hope dear doctors are okay. I mean, at the end, little bit, I think everyone is a bit silent, but yes, we'll be fine actually. All right. So thank you so much, guys. We do have a inquiry zone in our inquiry section. And those of you didn't receive our note yet, please leave me a message in the messenger. I'll take some rest and tomorrow morning I'll start sending again actually. Sorry, your study might get hampered a little bit, but during admission period, we usually receive suddenly massive amount of admissions. That's the thing. I'm going for a mock now. Yes, to introduce you the mock. What I'm going to do is upload a question in batch 59, and all you need to do is download it, and the answer sheet will come up into the same group actually. So if you just allow me just few seconds to upload. Uploading mock, just stay with us in a second. We are posting respiratory system mock now. So mock posted just now. Okay, so here we go. Yeah, if you guys can see, I just posted the mock. You download it and you can take like a 15 or 18 minutes of time to finish it, and the answer will be also posted here. Okay, I repeat, guys, answer will be posted in 30 minutes. Okay, you can write it down your answer in a page and post below these particular things. Okay, just post anything like any pictures or something which you can take and do it actually immediately. Okay, computerized ones we will take in future actually, don't worry. Those are the bigger monks, we take the computerized. This one is a with question, and answer will be posted shortly. You can write your name, and one answer is B, three answer is C, and take a picture and just post below. Okay, guys, thank you so much. First day it can be confusing, but you can follow others, what others are doing, it will be fine. Thank you, guys. You can download it actually. Yes. Yeah, no, we are cleaning, in the process of cleaning the group, so don't worry, my dear. We're in a process of cleaning the group. It's already 8:61. Our team is um, already cleaning it actually. So by 2-3 days, it will be cleaned actually, totally. We invited a lot of people for trial, so it will be fine, guys. Thank you so much, guys.